In this section on prenatal care, we're going to be reviewing the first, second, and third trimesters, as well as reviewing some specialized screening tests in obstetrics. So during the first trimester, we're going to have visits every 4 to 6 weeks. At the initial visit, we'll perform a comprehensive history and physical examination, as well as a risk assessment, which is going to include nutrition, exercise, smoking risk, environmental hazard, alcohol or recreational drug use, domestic violence screening, and seatbelt use. We're also going to attempt to establish an accurate gestational age, as we discussed in the first lecture. Each assessment is going to need to include maternal blood pressure, maternal weight, and an assessment of the fetal well-being. At the first prenatal visit, a standard panel of laboratory tests should be obtained on every pregnant woman. This panel can be specialized based upon risk factors. The standard panel typically consists of Rhesus type and antibody screen to detect antibodies potentially causing hemolytic disease of the newborn, hematocrit or hemoglobin, and MCV to detect anemia and screen for thalassemia. An MCV of less than 80 in the absence of iron deficiency suggests a thalassemia, and further testing with hemoglobin electrophoresis is indicated. Next, cervical cytology should be obtained for women who are over the age of 21. Rubella immunity testing should be performed, and if non-immune, the patient should be counseled to receive postpartum immunizations. A urine culture should be obtained, given that pregnant women with untreated asymptomatic bacteriuria are at a high risk for developing pyelonephritis. Syphilis testing, HIV testing, and hepatitis B antigen testing are done to prevent perinatal transmission. And finally, gonorrhea and chlamydia testing is performed. Between 11 and 14 weeks, we can perform an ultrasound, which not only confirms the gestational age, but also checks for nuchal translucency. This, along with serum markers, which include pregnancy-associated plasma protein A, or PAP-A, and beta-8-CG, are combined with the nuchal translucency to come up with the first screen in order to come up with a composite risk for Down syndrome, trisomy 18, trisomy 13, and Turner syndrome. It's also important to note that fetal heartbeats can be heard at the end of the first trimester with Doppler. So let's review a case presentation which drives home a key point. We have a woman who presents for a checkup at 12 weeks, and we're asked which of the following is the most accurate method for establishing gestational age. Given the following responses, we would choose ultrasound, which is going to be the most accurate way. At this point in pregnancy, beta-8-CG levels are going to be varying widely, and in fact are probably going to be on the decline after about the 10-week gestation. Pelvic exam is very unreliable and may change with multiple gestations. Fundal height can also change with multiple gestations, and we may not even be able to feel it at 12 weeks gestation. The last menstrual period in many cases may be unreliable, and an ultrasound this early in pregnancy is going to be the most reliable method of determining gestational age. Moving into the second trimester, we have a couple additional genetic screening tests that we can offer mothers in order to risk assess for chromosomal abnormalities. We offer these tests between 15 and 20 weeks gestation and offer either the triple screen, which includes maternal serum alpha-fetoprotein, beta-8-CG, and estriol, or the quad screen, which adds inhibin A to the triple screen. Now, if asked on the Step 2 exam what you would expect for trisomy 21, the answer is going to be an elevated beta-8-CG and inhibin A with low maternal serum alpha-fetoprotein and estriol. If asked what you'd expect for trisomy 18, the characteristic markers would include low levels of beta-8-CG, maternal serum alpha-fetoprotein, and estriol. We take a close look at increased maternal serum alpha-fetoprotein, as this may indicate a dating error, neural tube defect, or an abdominal wall defect. You may be given on the Step 2 exam an elevated alpha-fetoprotein along with this ultrasound, which shows the classic banana sign in a 16-week fetus. Now, this banana sign is created by compression of the cerebellum, and the answer in this case as to the abnormality would be a neural tube defect with downward displacement and compression of the cerebellum in the posterior fossa. There are a few final points in the second trimester. We should be able to auscultate the fetal heart rate easily at this point. Normal fetal heart rate should be in the 110 to 160 beat per minute range, with higher rates typical in earlier pregnancy. At about 16 to 20 weeks, the mother will experience quickening or fetal movement. Oftentimes, multiparous mothers will experience this a little bit earlier. We can also offer the anatomic ultrasound at 18 to 20 weeks in order to assess all key components of the fetus. During the third trimester, visits become more frequent every 2 to 3 weeks until 36 weeks gestation, followed by weekly visits after 36 weeks. We'll begin to monitor for signs and symptoms of labor. The first of these are Braxton Hicks contractions, which often occur during the third trimester. These are sporadic contractions and do not cause cervical change or dilation. If they become regular, the next step should be to check the cervix in order to rule out preterm labor if occurring before 37 weeks gestation. So we're going to review a couple of the key screening tests that we do in the third trimester. In all of this, there's a physiologic connection. It's important to understand the physiologic changes of pregnancy and why we do these screening tests. It'll make understanding what we order and what to do with the abnormal results a lot easier. More important to understand the physiology than to memorize the box. So at 27 weeks, we order a CBC. This is obtained at the outset of pregnancy and again during the third trimester. Now, iron deficiency is the most common cause of anemia in pregnancy, and if the hemoglobin is less than 11, we would probably go ahead and replace with iron orally, along with adding a stool softener. Remember the physiologic connection with the GI motility already being slowed, and iron can be constipating, so we go ahead and add the stool softener in order to prevent this. Now, iron deficiency is the most common cause of anemia in pregnancy, but folate or B12 deficiency or other hemoglobinopathies need to be ruled out if appropriate.
Also at 24 to 28 weeks gestation, we perform a glucose tolerance test.
Now, we do this to screen for gestational diabetes. The physiologic connection here is insulin resistance in pregnancy, induced in part by human placental lactogen. Now, if this screening test is elevated beyond 140, we would need to perform a formal oral glucose
Challenge
test.
At 36 weeks, gonorrhea and chlamydia testing are repeated in high-risk populations and treated if positive in order to prevent chlamydial or gonococcal disease in the newborn. At 24 to 28 weeks, we repeat the CBC obtained in the first prenatal visit if anemia was present,
as well as rectovaginal culture for group beta strep, and treat with appropriate antibiotics during labor in order to prevent neonatal sepsis.
So in order to fully understand screening for gestational diabetes, let's review the screening test. The 50-gram glucose challenge test is a fasting or non-fasting ingestion of 50 grams of glucose, followed by a serum glucose test 2 hours later. If this is abnormal, the 3-hour glucose challenge test is performed, which is a fasting serum glucose, followed by ingestion of 100 grams of glucose, and serum testing at 1, 2, and 3 hours. Elevated glucose levels at 2 or more of these checks is abnormal.
So we're going to wrap up now by discussing several specialized diagnostic tests. These invasive tests are offered either outright or in conjunction with abnormal screening tests as discussed earlier.
The chorionic villus sampling is done at 10 to 13 weeks gestation.
And obtains a fetal karyotype by inserting a catheter into the intrauterine cavity to aspirate chorionic villi from the placenta. The resulting karyotype can be used to diagnose chromosomal abnormalities.
The second trimester amniocentesis is performed between 15 and 20 weeks. Early amniocentesis can be performed between 11 and 14 weeks, but has less satisfactory results and higher rates of post-procedural complications than later amniocentesis. Like chorionic villus sampling, the amniocentesis obtains a fetal karyotype.
A needle is placed transabdominally into the amniotic sac in order to withdraw amniotic fluid and obtain the fetal karyotype. Finally, percutaneous umbilical blood sample, or PUBS, is a specialized test obtained in cases of Rh isoimmunization when a fetal CBC is needed. Similar to an amniocentesis, a needle is placed transabdominally and into the uterus in order to get a blood sample from the umbilical cord.